be offended if you walk out. I completely understand if you have to get going. But at very last, I'm going to talk about one of the complications that happens for patients with chronic pancreatitis. We were trying to get at this a little bit during the earlier question and answer period, and that is diabetes. So diabetes being really an end stage of chronic pancreatitis when you have enough scarring throughout your pancreas that your islet cells no longer work well enough to produce the insulin that you need. And so I'm going to go through this relatively quickly, but kind of focused on the questions that people ask me about diabetes when they come into clinic. And first of all, people will say, well, what type of diabetes do I have? Because it's very confusing because everyone talks about type 1 and type 2 diabetes, and this is a little bit different. People want to know how common it is, who's going to get it, why does it happen, and most importantly, perhaps, how are we going to treat diabetes when it does develop. So just for anyone who might not be familiar, quick overview of the endocrine portion of the pancreas. So the islets make up about 2% of the pancreatic tissue. The islets are actually a cluster of cells, so about half of those cells are beta cells that make the insulin, and there's other cell types like alpha cells that make the glucagon. And in order to not have diabetes, so for each of us who are walking around without diabetes, our body needs to, number one, make insulin, and number two, actually be able to respond to that insulin. So people who either can't make enough insulin or their body doesn't respond to the insulin, that's when you develop diabetes. So what type of diabetes do you have if you have chronic pancreatitis and diabetes? And it's really confusing because all of our diagnostic codes and our processes for getting insurance approval and all of that, it all focuses on type 1 or type 2, which are probably the most common forms of diabetes, certainly type 2 being the most common. So there's different terminology that's used for diabetes and chronic pancreatitis. The GI community oftentimes refers to it as type 3C diabetes. That comes from a table that the American Diabetes Association put out where there was there was type 1, type 2, and then a third category of diabetes, and this was letter C in the third category, therefore type 3C. That might be falling out of favor again, I'm not sure. So pancreatogenic diabetes is the other term that was used before type 3C, and now I see that kind of coming back. If you've had surgery, it might be post-pancreatectomy diabetes. I use that code a lot in my population. And then people who have cystic fibrosis, which sometimes can be a cause of pancreatitis, may have cystic fibrosis-related diabetes. So a lot of different terminology there, which makes it kind of difficult. If we just look at diabetes in the U.S., people think about type 1 and type 2 being far more common. But probably about 1 to 8% of the diabetes in the U.S. is, we don't know for sure, this is kind of estimates, but probably about 1 to 8% is type 3C or pancreatogenic. And most of that is chronic pancreatitis, some of that also being cystic fibrosis. So I'm not going to talk much about acute or recurrent acute pancreatitis, although we know now that there is some injury in those conditions and some people do go on to develop diabetes. But most classically, this is associated with chronic pancreatitis, so that's what I'll focus on. And how many patients actually get diabetes? It depends on the study you look at. So anywhere between 25 to 75%. And I think if you follow people long enough, it's probably 50% or higher who are either frankly diabetic or at least kind of pre-diabetic on the verge. So it depends on the cause of the disease, how long they've had it, how long you're following this population, what other kind of things they've had, like pancreatic surgery. We certainly know that people who have had the disease longer are higher risk. If they have exocrine insufficiency, there is a correlation between that and diabetes, and that's because the exocrine insufficiency is just a marker of more damage to the pancreas. Pancreatic calcifications, again, a marker of more damage. People who have had surgery, especially if they have part of their pancreas taken out and they don't have their islets transplanted, are going to be at higher risk. And then actually things that we think of as causing type 2 diabetes or increasing risk for type 2 diabetes, obesity and a positive family history of diabetes. Even in people with pancreatitis, that might push them over the border to getting diabetes. And so that's also a statistical risk factor. So we think that hyperglycemia or diabetes is primarily due to impaired insulin secretion in chronic pancreatitis. So you might have episodes of acute pancreatitis with necrosis, chronic scarring from fibrosis, and even in the absence of scarring, some inflammation that causes dysfunction of the beta cells, and all of that contributes to impaired insulin secretion. Probably have to reduce your beta cell capacity by 70 to 80% to actually manifest diabetes. So you have a lot of reserve. But other people are finding that there is another component in chronic pancreatitis, which may be an impaired responsiveness or sensitivity to insulin. So there may be some insulin resistance that's also happening in this condition. But what we know is acute pancreatitis-related diabetes or chronic pancreatitis diabetes are much more likely to need insulin treatment. So there's a proportion of patients needing insulin treatment in a large series from the United Kingdom compared to type 2 diabetes. So insulin treatment is very common, suggesting that we are replacing insulin in this condition. So there's very little evidence-based guidelines, honestly, to guide how we're going to screen and treat people with diabetes and chronic pancreatitis. There's one consensus statement that's out from 2012 from the Pancreas Fest meetings that happen in Pittsburgh every year. And so I think there's fairly good consensus that if you have chronic pancreatitis and you don't have diabetes, you should be at least getting screened for diabetes. So you should be screened once yearly, and that should probably at the very least involve a fasting glucose and a hemoglobin A1C level, which is a marker of average blood sugar in the past 3 months. And then you might end up adding a more complicated test like an oral glucose tolerance test or some sort of meal challenge test to get an idea of postprandial glucose. So everyone should be screened in the setting of chronic pancreatitis. Once pancreatitis or diabetes is diagnosed, of course, we have to make a treatment plan. So here the tough thing for endocrinologists and GI docs is all of our treatments are studied in type 1 and type 2 diabetes, not a single specific treatment trial for people with type 3C or pancreatogenic diabetes. So we know what treatments are available from the type 1 and type 2 populations. So there are non-medication things, lifestyle changes, and then there are different medications that range from, broadly speaking, pills, oral medicines, injectable medicines that aren't insulin, so non-insulin injectables, and then there's insulin. So what about lifestyle modification? So this is really a conventional type 2 diabetes approach. It is basically limiting the amount of carb you take with a meal, exercising, maintaining a healthy weight. It might help if you are someone who is overweight in particular and you have diabetes. This could be a useful tool. I'm not sure how useful it is if you are not overweight and you're just not making enough insulin. And obviously there's some practical challenges, so it can be a tough thing to ask someone who has a dietary restriction from their chronic pancreatitis, they can't eat fat, to then also limit their carbs, or to go out and exercise in a way that is actually efficient for weight reduction or insulin sensitivity. So there's some real challenges, but there may be some select patients who do benefit from that, and certainly we want everyone to maintain a healthy body weight. So what about oral medications? So there are a few patients with pancreatitis and diabetes who can do okay, at least for some time, on oral medications. Most of them, or really all of them, not studied specifically in pancreatitis. And there's a number of pills now on the market for type 2. The most common categories probably being the metformin, the spunureas, and the TZDs like pioglitazone. And more recently, a couple new categories on the market. One is called DPP-4 inhibitors, things like sitagliptin therapy, that actually those and GLP-1 analogs have gotten a lot of press for a potential pancreatitis risk. So generally, we actually try to avoid those in pancreatitis. And usually the mainstay for pancreatitis, because it has the most clinical experience, is just to use metformin if you're going to start a pill. And then there's some non-insulin injectables that we can use, GLP-1 analogs. They're pretty widely used in people who are obese with type 2 because they also help with weight loss and they augment your own body's insulin secretion, and they're good diabetes drugs, but they've been really controversial. And that's because there is maybe a safety signal of risk of pancreatic cancer or pancreatitis with these drugs. Now that's been really debatable and refuted, certainly in animal studies at high doses. They carry those risks, and there are case reports, many case reports of people getting pancreatitis being on GLP-1 analogs. But for the average patient with type 2, that's really controversial. But because of that, I think the general consensus in my feeling is that these are probably not appropriate drugs for someone who already has a risk for pancreatitis to then go on GLP-1 analogs. So these non-insulin injectables we largely avoid. And probably our mainstay of therapy is really insulin therapy because we're replacing what the body is deficient in. So we're giving back these people the insulin that their body no longer makes. And certainly if you had surgery and you've had a surgical resection, this is the primary therapy, is insulin therapy. And the conventional way to do this, usually our first line is to do an insulin pen, or once in a while someone might do a real old-fashioned vial and syringe approach. But we have long-acting insulin types and rapid-acting insulin types, so they mimic different physiology of our pancreas. So you take a long-acting insulin to kind of replace what the pancreas trickles out all the time, and then you take a rapid-acting insulin because each time you eat, your body's supposed to make a bolus of insulin with the meal. And we can also do this with insulin pumps. So many of our kids will use insulin pump therapy, and many adults who stay on insulin will also like insulin pump therapy. It's all external. There's no surgery involved in insulin pump, but it's super convenient because you're kind of wearing your insulin around all the time. You don't have to poke yourself every time. You put everything through a little computer system to give a dose through your insulin pump. There is an inhaled insulin. I don't typically use it. The old inhaled insulins on the market had a risk of lung cancer with them, so they make me a little bit nervous for long-term use. So I largely avoid that and just keep to sub-Q insulin. So if I see someone who has a chronic pancreatitis, everyone's undergoing this annual screening where they should at least be getting fasting glucose, A1C. And if we diagnose someone with diabetes, then obviously we need to put them on treatment. And I would say that really the two common treatment approaches are to use insulin or metformin, or a combination of insulin and metformin, and it really depends on the patient. So someone who is really thin, who has severe insulin deficiency, has a higher A1C, is always going to be better served by insulin therapy. But there may be a few people who are obese, who have more of a kind of a type 2 adult onset diabetes look to them, who have a better A1C, so maybe they're kind of pre-diabetic or on the borderline, or you might actually start off with a pill, metformin, but you're probably eventually going to have to progress onto insulin therapy as well. So in conclusion, diabetes develops in pancreatitis largely when the pancreatic islets are too damaged to produce all the insulin that our body needs, and some patients may also just not respond as well to that insulin or have insulin resistance. We should make sure everyone with chronic pancreatitis is being screened for diabetes and tested once a year because we know that this is a very frequent complication of diabetes. And when diabetes is diagnosed, the two probably safest and most common approaches based on our current knowledge are to treat with insulin or in select patients a metformin pill. And the other treatments may have, may be applicable too, but they just really haven't been studied. So I think we need more study of all the treatments, but particularly some of the newer type 2 diabetes drugs. Sorry, you've seen this picture like a million times today, so I will just end it with the picture of the multidisciplinary team, and hopefully that wasn't like whirlwind pace, but I want to get you guys out of here so you can enjoy the day, and thank you everyone for attending, and we're recording this, so hopefully we'll get this posted online too for anyone who'd want to view it after the fact. And I don't know, Sonia or Patrick, is there anything else you need to add before we wrap up? Get involved with the National Pancreas Foundation in Minnesota. See Sonia there so you can get involved, and because we certainly want to grow and have more people. All right, thank you. Thanks for your patience and staying so long. Oh, take some food if you're hungry on your way out.
You have been disconnected from the meeting.